right, I'm Elizabeth Pavlisco, and I appreciate the opportunity to share this summary with you, which really means I spent a couple hours cramming several hundred slides down into 30 minutes. So I'll try to do my best to cover everything that we covered. It was really a wonderful session. There were three main parts. We aim to look at patterns of injury in the lung which aren't typically classified as rejection. And I think the original hope was to look at some acute lung injury, arteritis, eosinophils, vault, things that have been in the literature over the last couple of years. We had two speakers cancel and we were able to replace one of them. But overall, great first part. Then we moved into new technologies and looked at what's going on in the molecular space as well as AI, and closed with some discussion and updates on projects and then a proposal for things moving forward. So the first talk centered on acute and organizing lung injury. The literature over the last 3 decades has established this pattern as associated with allograft loss. Most of these were small single-center studies, and some of them associated acute lung injury with a pattern of restrictive allograft syndrome, or RAS, which you know is a phenotype of CLAD, as well as with DSAs. And there was really a need to understand the frequency with which this was occurring in the lung allograft in a multi-center perspective fashion, looking at the occurrence, timing, impact on long-term graft outcomes, as well as looking at donor and recipient factors with respect to the development of acute and organizing lung injury. So this was done through CTOT 20. This is a NIAID-funded study, and the main aim was to look at clinical factors and biological mechanisms behind CLAD after transplantation. This involved 5 North American centers. All of them were adult lung transplant patients between 2015 and 2018. We had around 800 patients fully enrolled and just under 5,000 biopsies. And so the data revolving around acute and organizing lung injury was just published about 3 weeks ago. And kind of the take-home points where we saw acute and organizing lung injury in around 41% of our patients. Of those, about 70% had a single episode of acute or organizing lung injury, whereas the remainder had repeated episodes. And if you look at it on the biopsy level, we were seeing it in around 5 to 6% of biopsies. With respect to timing, there was no clinical significance of early acute lung injury or organizing pneumonia. I think the thought that is defined as occurring within 90 days of transplant. However, late ALI or OP was associated with a 2 to 3-fold elevated risk of progression to CLAD or allograft loss as defined by death or retransplantation. When we looked at different donor and recipient characteristics to determine what was putting someone at risk for an episode of late acute lung injury or organizing pneumonia, the ones that were significant were grade 3 PGD at 72 hours, a higher degree of donor-recipient HLA mismatch, bacterial or viral respiratory infection, DSA detection, and an early acute or organizing lung injury event. We then dug a little bit further into lung injury. Sam White out of UCLA presented some data that was looking at specific markers in BAL fluid for acute lung injury. And there are so many things that the lung is assaulted by. And I think our colleagues really have an interest in knowing when is an insult significant and when is it not. And so they had looked at CXCL9 and CXCL10 in BAL fluid, had shown that these were significantly elevated in the setting of acute lung injury, and then further went on to show that it's both the injury plus high levels of CXCL9 or CXCL10 that are needed to cause CLAD. I think as far as summary and future directions, the non-rejection injury patterns, they can be accompanied by, they're not always, but can be accompanied by elevated injury markers in BAL fluid, in this case CXCL9 and 10, and that these are associated with an elevated risk of CLAD. And so the hope is that this might be used to help better stratify patients who are at risk, whether or not we're able to see the injury on a transbronchial biopsy or not. Some sampling error would certainly be an issue. We then moved into Vault in the lung allograft, and I find this area particularly fascinating because we see it all the time. Dr. Dan Kriesel, who's a thoracic surgeon out of the University of Washington, St. Louis, took us through a series of really eloquent studies in a mouse model looking at lymphoid aggregates in the lung. And so if you go back to 2012, there's a paper suggesting that the lung allograft acceptance is associated with lymphoid neogenesis. And so some of Dan's studies showed that FOXP3 cells do accumulate in Vault in the lung. And in his mouse model, he is taking a set of lungs, transplanting them into a mouse, using diphtheria toxin receptor to deplete that mouse of FOXP3, then transplanting it into a second recipient, and then looking to see what's happening with that allograft. And in this setting where FOXP3 was depleted in comparison to a control case, they showed that there was significant injury to the allograft, that the pattern of injury present was similar to that seen in antibody-mediated rejection. And this is comparing and contrasting respiratory epithelium, which in the affected lung shows loss of club cell secretory protein. And taking this a little bit further, in that second recipient, following depletion of FOXP3 retransplantation, he showed us a scenario where recipient B cells were depleted, and what happened was that the allograft was accepted, and there was no evidence of antibody-mediated rejection. So I think his thoughts were that depletion of graft-resident FOXP3 cells, at least in this mouse model, showed a pattern of injury that's similar to antibody-mediated rejection, which was dependent on recipient B cells, CXCL13, and that this is all occurring kind of locally within the lung allograft, possibly setting it apart from other solid organ transplants. So his conclusions were that rejection and tolerance are regulated at the level of the lung allograft, at least in this the mouse model, and that tertiary lymphoid organs maintain a tolerant state. And I think there are other studies in other organ systems which contradict that, and so I think there is definitely, this is an area of need. I have a ton of cases with Vault in the lung, and I would love for someone to take those and run with them. We then moved into section 2. This looked at what's going on in the molecular landscape as well as AI. And we started off with a presentation by Dr. Carolyn Glass looking at machine learning and lung transplantation. And I think this is really in its infancy. There's been one, so I think one of the areas of interest is because our CAPAs are so terrible when we look at our inter-observer agreement as far as grading acute cellular rejection, so A grade, B grade, et cetera. But could we use AI to better assess for acute cellular rejection versus normal lung tissue? So far there's only been one report of this. This was an abstract by Davis and colleagues. It was presented at a meeting, I think, during the COVID era, so since we last met. And they were able to show that their algorithm was able to distinguish ACR from normal lung tissue around 95% of the time. And I think this was a single center, relatively small number of samples, so definitely multi-institutional validation and testing is needed. And so right now we're mostly seeing AI being used in the setting of diagnostic work in lung transplantation. We haven't really moved into the prognostic setting yet. Another question that she proposed to the group was, can a convolutional neural network distinguish ACR from infection in the lung? And I think the reason that she posed this question is because we're now transplanting COVID-19 positive donors. At this particular institution, they had done a series of 12 hearts and 2 lungs over about a year. And as far as follow-up, I think the pathologist is always concerned, are we seeing COVID-related myocarditis or a COVID-related infection in the lung, or are we really looking at rejection? Because the 2 histologies are actually quite similar, and there had been a report of transmission previously. And so here's an example of what COVID-19 looks like, involving bronchial, involving perivascular inflammation, all great mimics. for what grade A and grade B rejection look like. I think we're not there yet, although this has been done in peripheral blood smears. And so right now, in the context of the lung allograft, machine learning, at least in the pathology space, it's different in radiology, is still in its infancy with a focus on diagnostics. We then moved on into the radiology space, where Sten Verleden from Belgium talked about CT scans and their diagnostic and prognostic value. And in 1993, CLAD was defined, and it was based on pulmonary function testing. We know that now that CLAD has evolved into 2 to 3 distinct phenotypes. You have restrictive allograft syndrome, you have an obstructive component known as BOS, and then you have what is a mixed phenotype. Still largely being defined by pulmonary function testing, but now we have some reports showing that radiology can really play a large role in this, specifically in determining total lung capacity, which can be helpful in distinguishing the restrictive and obstructive phenotypes. And so he showed a couple of different studies. This one in particular had diagnostic value using quantitative image analysis on high-res CT scans, distinguishing BOS from RAS, looking at air trapping, which was more prevalent in BOS, versus interstitial fibrosis, more prominent in RAS, and then you have the mixed phenotype in the middle. A couple of studies have looked at the prognostic value of CT scans. This one in particular looked at progression over time, and patients who had more rapid progression on imaging studies had a much worse survival than those with slower progression. So not necessarily unexpected, but interesting to see that it can be stratified using CT scanning alone. And then this study by Sten's group looked at the distribution of fibrosis in the lung. Was it apical, basal, or diffuse, and the prognostic value of those. In this case, apical fibrosis had a better survival than basilar or diffuse. And so as far as his summaries, so software packages are increasingly being used to distinguish CLAD phenotypes because not all institutions use pulmonary function testing the same way. I know at least at our institution, total lung capacity is not typically measured on follow-up visits. And then with a given phenotype, CT can be used for prognostic stratifications. And so his thoughts are that in the future it might become more important than physiology. Moving into the molecular landscape on lung transplant, we had Ben Adam take us through kind of what's going on in this space. So there are many different centers looking at different platforms and different lung transplant samples and assessing those. And there are 2 that I think I'd like to highlight for you. So there's the work that's being done by Kieran and Phil Halloran, looking at the molecular microscope and T-cell mediated rejection. I think since we last met in 2019, their cohort has grown, and they have shown that in transbronchial biopsy samples that the TCMR scores correlate with A grade greater than 0, and that in mucosal biopsies that TCMR scores correlate with a B greater than 0. But I think what might be the main take-home message here is that the molecular TCMR associated with graft loss, but not necessarily histology or with the presence of a DSA. The most recent study to come out of this group was in April of this year, and again, the cohort had grown. This time we're looking at CLAD, gene transcripts that could be predicted with CLAD. And so they have a series of molecular classifiers that are able to predict CLAD with an AUC of 0.7 without being corrected by time, and then by 0.87 with a time correction. Ben showed a bit of his work in the renal and in the heart space. They have a validated platform using microarray technology. But he did mention that within the lung space, that this microarray-based gene expression profiling using FFPE, while it's really easy to do, that we still are in need of further refining these transcripts. So as far as looking at ACR, AMR, and infection, we aren't really able to stratify these, I think, the way we would like to, and so more work is needed in this area. It's not not what, we can't really look to what's been done and what's been shown in the kidney and the heart. It doesn't quite translate over to the lung the way we would hope it would. So some conclusions, as I mentioned, further work in the lung is needed, as we can't really use what's been done in the kidney and the heart. And then lastly, for the molecular side of things, we had John Greenland take us through the molecular diagnosis of airway inflammation in CLAD. And so he is out of UCSF and has a particular interest in the large airways. And we know that in the lung is a little bit unique in that it's exposed to the external environment, and infection and aspiration often drive inflammation in these large airways, which are not captured by the current B grade. Those are limited to bronchioles. And if you asked a series of 8 lung transplant pathologists what they do with airways, you're going to get 8 different opinions. And so, so John is focusing on lymphocytic bronchitis, and he's terming this grade E rejection. And so he looked at airway brushings from these large bronchi with inflammation with grade E rejection and compared those to controls, and was able to come up with a set of gene transcripts that were unique. He compared those then to A and B grade rejection, and what he showed was that the E grade, or the lymphocytic bronchitis, aligned more with A grade than it did with what's going on in the bronchioles, which I think is interesting. He then took this work using airway brushings down into the small airways. So small airway pathology in the lung can be a little bit frustrating because they're really often not well sampled on transbronchial biopsy. When you do get them, they're often distorted, and it can be really difficult to assess for the presence of CLAD, the presence of constrictive bronchiolitis obliterans. And so looking at these small airway brushings, he was able to show that the gene expression for CLAD is actually, you see greater changes on these airway brushings than you do on a biopsy, which is not necessarily surprising, but it would be a great utility because we're not often able to demonstrate this on a transbronchial biopsy. All right, so his conclusions were that gene expressions in the allograft can be used to identify early CLAD, even when the transbronchial biopsy is normal, so not surprising. And this can be used to help predict time to retransplantation or death. It may even provide the opportunity for modification of therapy in the setting of a normal biopsy. But multi-center validation studies are needed and are underway. All right, I think there's been a huge amount of interest in donor-derived cell-free DNA, and Debbie Levine, who is a lung transplant pulmonologist, recently relocated to Stanford, took us through kind of the assessment of what's going on in the lung space with donor-derived cell-free DNA. And I think that the kind of the backstory is that we are all kind of hunting for some type of early sign that shows us that the lung is headed down the wrong path. We're not always able to capture changes on transbronchial biopsy, and so what else could we use? And so in the context of donor-derived cell-free DNA, looking at different pathologies, so CLAD, acute cellular rejection, infection, and antibody-mediated rejection, we're not at so you can distinguish normal from any of those, but you can't distinguish one from the other at this time. And so really, it's a marker of injury, and it might be a great tool for monitoring, but we're not at a place where we can use it to guide therapy at this time. Right, so lastly, I'll touch upon a few project updates. So we have the Banff Lung AMR molecular signature project. I think this was first mentioned at the meeting in Pittsburgh. So this is something that Ben is working on. And the current state would be we're still looking for cases of AMR in the lung to help with this project. So I would encourage any of you who have clear cases at your institution who'd be willing to send in to Ben. That would be fantastic. We also took a look at kind of an update on what's happened with LASHA. So this is something that evolved out of a kind of sidebar discussion at the meeting in Barcelona. Further work was done around the Pittsburgh meeting, and then this was published in July of this year. So in the lung transplant setting, there are many different terms used for the same pattern of injury. So I might call something a fibrinous alveolitis, you might call it exudative alveolitis, and someone else might call it AFOP. And so what we needed was a standardized template for assessing biopsies, at least for starters in the research space. And so this is what was proposed. It's now out there and available for use. It captures what type of biopsy specimen are we looking at, what stains were performed, is it adequate, assessment of acute and chronic forms of rejection, and then looking a little bit deeper into what's going on in the alveolar septa as well as the intraalveolar space in terms of injury. There's a grading system, 0 through 3, 0 being pathology is not present, 1 is it's focal, 3 is it's present in greater than 50% of sample tissue pieces, and 3 would be that it is diffuse. We also have a list of kind of other things that we see in the lung, which we know are important, but I don't think we're exactly sure how important that they are. And that kind of takes us into, there's a summary assessment area at the bottom, so that the pathologist can provide here are all the findings, and this is actually what I think is going on when integrating the clinical history. And so taking that Lasha template and thinking about what do we really need in the setting of lung allograft pathology at the moment, it's really looking at pathology that we don't consider to be rejection, but we think might have an impact on graft outcome. So you could call it PAVO, pathology associated with graft outcome. And how do we assess this? So we have this really nice Lasha template that goes through pathology seen in different areas of the lung. And can we use that as a starting point? I think the answer is yes. And the proposal would be to take all these different pathologies and use the Delphi or Delphi method and really just have kind of a consensus of whether or not these lesions can have an impact on the graft. And so I think ideally we hope to get pathologists from the US, Canada, and Europe just kind of putting together a list. We came up with it around 18 to 20 yesterday. And we would say, is X lesion, if you aren't familiar with this method, this is something that was relatively new to me. Learned about it a little bit more this year in the context of antibody-mediated rejection. So the ISHLT group has come together to put together a new consensus statement on AMR in the lung using this method. And so you would say, are eosinophils associated with graft outcome? Should they be considered rejection? And you would grade it from a -5 to a +5. +5 meaning, yes, I strongly think that lesion is associated with graft outcome. -5 would mean, no, it's not. And if you're a 0, you're neutral or relatively undecided. So I think that's kind of the way we hope that this will move forward. And hopefully we can come up with a table of different lesions, whether or not they can be associated with other etiologies, whether or not it's something that's associated with AMR, the presence of a DSA, what our assessment is after the Delphi method, and then some resources to support that. So that is the end of the lung summary.
At least you chose a different lake.
I went there yesterday. It was the most beautiful person.
Okay, so technically we have a 30-minute break, but I think people might want to get out of here. Should we keep going? Check out what you say we should keep going?
Yeah. How many people have still got to check out their hotel?
You want to use now the break to check out?
I could do.
And then come back? Quickly, is that okay? So, then go and check out and check in here again. In, I don't know, 20 minutes or so. Okay? Quarter after 10.